Thank you very much, Mr. Chairman. Thank you very much, moderators, and everyone to be here. Today we are going to be talking about can CBCT-derived biomodels replicate skeletal anatomy? And there are going to be two objectives regarding this. We are going to go into the details later on. So before we go into the details, we need to know what is biomodeling. So first we have the model, which we have on the computer screen. Then we print it into a proper anatomical structure. Now, the advantage of having the anatomical structure is that it can reduce the operating time during an operation, and it can also reduce the bleeding if you train beforehand going to the operation theater. So it has a lot of advantages in dentistry as well. You can teach the students how to train on the models as well. So the objectives will be as follows for this presentation. In the first objective would be, we were going to evaluate the quantitative accuracy of the 3D printed models. And the second objective would be to see if the models can visually and haptically replicate a real bone structure or not. So the methodology consists of the following steps. So first, we acquire the DICOM data of a patient. In this case, we acquired a patient from the orthognathic surgery dataset, and the requirement were that the patient should have high trabecular bone structure and a normal anatomy. Following that, the next step is segmentation. So in segmentation, you have different types of segmentation techniques. The problem is that if you apply only automatic segmentation, which is also called thresholding, if you apply that, then all the anatomical structures cannot be properly demarcated. So for that, we utilized manual segmentation, that is, a person is manually delineating all the skeletal structures and also the dental structures as well. So this is the process of the 3D printing from a biomedical point of view. So once you have a scan, then you segment the structure, you have an STL file, which we acquired. And after checking the accuracy, the next step was 3D printing. Now for this study, we acquired 6 different types of technologies, which are the state-of-art printers right now in dentistry. It consists of multi-jet, color jet printers, digital light processing printers, stereolithography, fused deposition modeling models, and laser sintering. Now keep in mind that all these printers were selected based on evidence, which is in the literature right now, that this printer offers the best accuracy in the market. So following acquiring the printed models, now we need to check the accuracy. So for checking the accuracy, we acquired a high resolution CBCT scan. Here you can see a Newtom Evo machine, which we use in our clinics. So we acquired the CBCT scan of the printed models. The reason why we did this is because we want to check the accuracy, how much is accurate to the real anatomical structure or the real anatomical mandible. So for that, first we have to do registration. Now, registration is a step where you take 2 anatomically same structures and you superimpose them together. Now, in this case, we did voxel-based registration through a software called Amira. It is very straightforward. It takes less than a minute to register 2 scans. Obviously, there are other methods of superimposing 2 scans, like point-based registration or surface-based registration. But right now, based on evidence, again, voxel-based is supposed to be the most accurate one. Now, once we registered the scans, we wanted to see how much is each structure accurate. For that, we split the mandible into the following halves. We segmented into the buccal segment. And in this study, we also made a trabecular segment, which has never been done before in the previous researches. If you see even online, you will not find studies which are trying to see if trabecular bone can be replicated or not with the 3D printing technologies in the market. We made a lingual segment, impacted third molars. We had partially impacted third molars with incomplete root formation to see how accurately the printers can print. And following that, we did a part comparison analysis. This is a color-coded map of all the structures' accuracy. In the middle, you can see the green color in the color chart. Green means that it is very accurate. If you go towards the red side, it means that it's bigger than the real anatomical structure. Or you can say in scientific terms, it's overestimating. And blue means, again, it's underestimating, which means it's smaller than the structure which you had from the CBCT scan. Now, these steps can be done with freeware softwares as well, but in this study, we used Trimatic software for the color-coded comparison. Now, based on our findings, you can see that around all the models had similar accuracy: multi-jet digital light processing, stereolithography, and laser sintering, except fused deposition modeling. Now, these are the results only for the teeth. You can see that the FDM technology didn't do that well. However, apart from all other technologies, FDM had statistically a significant lower scoring. So this proved the point that FDM is not good for replicating teeth. Second, we looked at the bony structures, buccal surface, lingual surface, and the trabecular surface. Now here you can see again, FDM is giving a not that good of a score with the trabecular structure. However, if you see, the accuracy is within the range of 0.45 millimeter. So overall, if we analyze the results, we see that there was no significant difference between all the printing technologies. But in reality, in a clinical situation, even 0.3 millimeter can make a difference. So these things need to be kept in mind. So overall, when looking at our findings, we found that all models were able to replicate the dental and the skeletal structures well. On the left side of the screen, you can see the most accurate one, which was the multi-jet technology or the material jet technology, which replicated the teeth, bone very accurately. And on the right side, you can see the FDM, that it wasn't that good. The post-processing might have caused some troubles with getting an accurate model. And overall, none of the models was able to replicate the trabecular architecture very accurately. You can find the results of these in the study, which is published in the Prosthetic Journal, and the link is above. You can see it. So the next step was to, based on these findings, we needed to see which model can replicate bone anatomy visually and haptically the best. So based on our objective findings and also some subjective analysis from maxillofacial surgeons, we acquired the best models which maxillofacial surgeons thought that were the most accurately replicating the bone anatomy, as well as haptically when they touch it, it feels like real bone. So we had again 6 technologies and 6 models: stereolithography, DLP, FDM, CJ, MJ, multijet, and SLS. And they are from the state-of-the-art printers, and all of them claim that they have the models which have the bone-like properties visually and haptically. But there's no research to figure out whether it's true or not. So what we did was we formulated a questionnaire. So we divided the questionnaire into 2 parts: anatomy-related questions. So in that, 22 surgeons were asked to touch the bone to feel it, if it feels like real bone, look at the color, does it replicate the real bone or not, and then some anatomical questions to see if it's replicating the anatomy properly or not. In the surgery-related questions, we performed a procedure called a bilateral sagittal split osteotomy. In that procedure, you cut the mandible and you move, it's an aesthetic surgery where you can move it either forward or backward. And we have certain questions related to the osteotomy. Osteotomy means bone cutting. So they wanted to see if it feels like real bone or not. Then they needed to screw in the screws, drilling that, and screw placement and screw removal. So, but for the surgery-related questions, 5 very experienced surgeons with an experience of over 10 years were recruited. So here an example how the anatomy-based questions were answered. So they have a virtual model on a screen and they have a physical model in their hand. And they answered the questions, the anatomical questions based on that, and also the feel, if they can feel it like real bone. So based on these findings, these are the findings of the anatomy-related questions. Here you can see that DLP is performing quite well with the feel, visual, cortical bone replication, and the medullary bone replication. And if you remember from the objective findings, FTM had the least accuracy. And again, these findings are also confirming that the FTM is visually not that efficient, and also the cortical and medullary anatomical replication is not quite good. So overall, based on these findings, so touch perception, cortical and medullary replication were the highest for the DLP based models, and the FTM models offered the least accuracy. Now the next step was the surgery related questions, which I said earlier that 5 surgeons performed surgery. So for that, first we prepared a surgical guide to perform the osteotomy. So they're going to cut the mandible here. Obviously there's a limitation to this study that the condyle is not there. The full mandible is not there. So that's one of the limitations of the study. That is why we couldn't perform the full sagittal split, and we performed the partial one. So once the guide was printed, the surgeons performed a buccal cut. Here you can see a buccal cut and a sagittal cut on the ridge here. After that, they drilled in the screw holes, inserted the screws, and also then removed the screws. So this is what we got from the surgery related questions. Now they were quite different from that of the anatomy. So here you can see that in the screw drilling holes, for example, FTM is performing quite well as compared to the anatomy-related questions. And the other technologies, none of them is offering a maximum score. So if you can see on the side, it says 5. So we did the scoring based on a Likert scale of 5. Higher the score means, more better it is. So none of them achieved a good replication for performing a haptic feedback result. And you can see that's quite variable. Some have better osteotomy, some have better screw drilling technique, screw drilling scoring, some have better screw insertion scoring, and again, screw removal also. So based on these findings, touch perception, cortical and medullary replication were highest for DLP again, and lowest for FTM. Keeping in mind, the laser sintering was also pretty low, and between DLP, material jetting, there was no significant difference. So this is the overall result for the anatomy. And for the haptic feedback, SLA models had the highest accuracy, the overall accuracy I'm talking about for performing the surgery, and laser sintering was least favorable. So you can see that not only the objective accuracy is important, but the visual and haptic feedback is also important from a clinical perspective. And to be honest, none of the models was able to achieve how you can say a full score, like a full anatomical and surgical score. So based on these findings, we reached a final conclusion that there is a need for multi-material printing, true. But again, which technology offers the best multi-material printing? You can combine the materials together, but can you combine the different technologies together? For example, we saw from our findings that FTM is performing well in some aspects, and SLA is performing well with screw insertion. So the next step would be to figure out if we can combine the different technologies together, apart from multi-material printing as well. And the second and the last conclusion is that the cost effectiveness. And now, again, for example, if you're putting an implant in a block of bone, it costs like around minimum 150 euros. So based on if we can achieve a proper printed mandible with proper trabecular structure and a cortical bone, the cost would decrease up to 70% per model. So it's important from both training point of view and also from research point of view that we get a more accurate bone, both haptically and anatomically. This was all, and this is our group. The link of our group is down, OMFS-IMPATH. You can find all our research there. And if you have any extended questions or you would like to get in touch with, my email address is below. And thank you very much for your attention, everyone. I'll give the floor to Mr. Hermes now. Thank you.